Osmosis is the process of water movement through a semi-permeable membrane from an area of low solute concentration to an area of high solute concentration. The water moves across the membrane by osmosis. The water moves into the compartment that is higher osmotic pressure. When the hypotonic solution is administered, it diffuses the interstitial fluid, decreasing osmotic pressure below the intracellular osmotic pressure. So when the hypertonic solution is administered, it causes water to leave the cells by osmosis, which will equalize osmolarity between interstitial and intracellular compartment. Measurement of the osmolality. So osmosis has a couple of concepts we need to know. Like osmolality is the number of the particles per unit of solution. We use the kilogram solution. So the osmotic pressure is the ability of a solution to draw the water across the membrane from one compartment to another. The osmolarity is the number of the millimoles in a liter of solution. So I give you the formula here to calculate the plasma osmolality. So plasma osmolality is equal to 2 times sodium plus BUN divided by 2.8 plus glucose divided by 18. Probably we don't need to know, but right now, at least we know our osmolality is related to the sodium, related to the BUN glucose, sometimes related to the alcohol too. So the normal plasma osmolality is between 275 and 295 osmoles per kilogram. So greater than 295, we have the water deficit. Less than 275, we have the water excess.
Normal values and ranges. Random urine osmolality typically ranges from 50 to 1,200 mosm/kg, depending on hydration status. After an overnight fast, first morning void, normal is 500, 800 mosm/kg, indicating adequate concentrating ability. After a water load, urine osmolality should fall to less than 100 mosm/kg dilute urine. The ratio of urine to plasma osmolality is often used. Urine osmolality/plasma osmolality is a simple bedside tool that helps assess the kidney's ability to concentrate or dilute urine relative to the state of hydration. It provides a quick, integrated view of antidiuretic hormone, ADH, activity, and renal tubular function. Greater than 1.5 appropriate concentrated relative to plasma, e.g., dehydration, prerenal azotemia. Less than 1.0 dilute urine, e.g., water loading, diabetes insipidus. Equals 1.0 isostenuria, fixed osmolality, kidney damage. Clinical interpretation. Urine osmolality. Interpretation. Greater than 800 mosm/kg. Normal concentrating ability, e.g., after dehydration, overnight fast. 300 to 800 mosm/kg. Indeterminate. Needs correlation with plasma osmolality and hydration. Less than 300 mosm/kg. Inappropriately dilute. May indicate water diuresis, ADH suppression. Less than 100 mosm/kg. Maximal dilution, normal after water load. Fixed at 300 mosm/kg, isostenuric. Urine osmolality equals plasma osmolality. Suggests severe renal impairment, loss of concentrating and diluting ability, e.g., chronic kidney disease. How it differs from urine-specific gravity. Urine osmolality measures actual particle concentration, which is directly proportional to the number of solutes and is unaffected by the size or weight of particles. Urine-specific gravity compares the density of urine to water and can be influenced by large molecules, e.g., glucose, contrast dye. Osmolality is more accurate for evaluating renal concentrating ability. urine osmolality is measured. Laboratories use freezing point depression or vapor pressure osmometry. These instruments measure the colligative properties of urine, specifically how solutes lower the freezing point or vapor pressure of the solution. The result is expressed as milliosmoles per kilogram of water, emosm/kg. This is a direct physical measurement and is considered the gold standard. How can estimate urine osmolality? In theory, you can estimate urine osmolality using the same formula as plasma osmolality, but applied to urine. Estimated urine osmolality, emosm/kg, equals 2 times urine Na plus urine K plus urine urea nitrogen/2.8 plus urine glucose/18. However, this estimation has significant limitations. Urine contains many other solutes, ammonium, creatinine, sulfates, phosphates, etc., that contribute to measured osmolality but are not captured by the formula. The formula assumes that sodium, potassium, urea, and glucose are the major osmoles, which is reasonable for plasma but less accurate for urine, especially in high output states or when unusual solutes are present, e.g., mannitol, radiocontrast dye. Clinically, the estimated value often underestimates true measured osmolality by 10 to 20%. So, in conclusion, urine osmolality is measured, not calculated. Always send a urine sample to the lab for definitive assessment. If you need a quick bedside approximation of urine concentration, urine-specific gravity, dipstick or refractometer, is easier, but it is less accurate than measured osmolality and can be affected by glucose, protein, or contrast agents. The estimation is not reliable for diagnosing conditions like SIADH, diabetes insipidus, or evaluating renal concentrating ability. How drugs that affect ADH alter urine osmolality. Urine osmolality is largely determined by the action of antidiuretic hormone, ADH, also called vasopressin, on the renal collecting ducts. ADH increases water reabsorption, producing concentrated urine, high osmolality. Drugs can alter urine osmolality by either interfering with ADH synthesis/release, blocking its renal effect, or altering the medullary concentration gradient. Lithium. Used for bipolar disorder, lithium is nephrotoxic and commonly causes nephrogenic diabetes insipidus. It enters collecting duct cells and disrupts the aquaporin-2 water channel trafficking, making the kidney resistant to ADH. As a result, urine osmolality falls, dilute urine, often below 300 emosm/kg, even when plasma osmolality is high. This effect can occur after months or years of therapy and may be irreversible. Dimeclocycline, a tetracycline antibiotic that directly antagonizes ADH at the collecting duct. It reduces the expression of aquaporin-2 channels, similar to lithium. Dimeclocycline is sometimes used therapeutically to treat SIADH, syndrome of inappropriate antidiuretic hormone, because it induces a controlled nephrogenic diabetes insipidus, raising serum sodium by increasing free water excretion. Urine osmolality falls significantly with dimeclocycline therapy. Alcohol, ethanol. Alcohol suppresses ADH release from the posterior pituitary by inhibiting osmoreceptor signaling and directly acting on the hypothalamus. The result is a transient water diuresis with production of large volumes of dilute urine, low urine osmolality. This is why alcohol consumption leads to increased urination and, if sustained, can cause dehydration and mild hypernatremia. The effect is short-lived as alcohol is metabolized. Loop diuretics, furosemide, bumetanide, torsemide. Loop diuretics inhibit the Na-K2Cl cotransporter in the thick ascending limb of the loop of Henle, impairing the countercurrent multiplier system. This reduces the medullary concentration gradient, so even if ADH is present, the kidney cannot maximally concentrate urine. Additionally, loop diuretics can cause volume depletion, which stimulates ADH release, a competing effect. Overall, loop diuretics typically lower urine osmolality compared to baseline, but the degree depends on hydration status. In euvolemic patients, urine osmolality falls. In volume-depleted patients, ADH may rise and partially counteract the effect. Case: patient, A 65-year-old woman presents with gradual onset of fatigue, mild headache, and nausea. She has no significant past medical history and takes no regular medications. Labs. Serum sodium equals 122 milliequivalent/L, low. Plasma osmolality equals 260 mosm/kg, low. Urine osmolality equals 450 mosm/kg. Urine sodium equals 45 milliequivalent/L. First, what is the plasma osmolality? Plasma osmolality is 260 mosm/kg, less than 275 mosm/kg. So this is hypotonic, true hyponatremia. That means there is an excess of water relative to solute in the blood. The low plasma osmolality rules out pseudohyponatremia, e.g., from severe hyperlipidemia or hyperproteinemia, or hypertonic hyponatremia, e.g., from hyperglycemia or mannitol. Step 2. Assess urine osmolality. Is it appropriately dilute? In hypotonic hyponatremia, the normal physiological response is to suppress ADH, antidiuretic hormone, and excrete a very dilute urine, typically urine osmolality less than 100 mosm/kg, often less than 50 mosm/kg after a water load. In this case, urine osmolality is 450 mosm/kg. This is inappropriately concentrated for hypotonic hyponatremia. It indicates that ADH is still active, preventing maximal water diuresis. Step 3. Determine the cause of inappropriate ADH activity. Once we know that ADH is not appropriately suppressed, we consider the differential diagnosis for hyponatremia with urine osmolality greater than 100 mosm/kg, often greater than 300. Common categories. Category. Examples. SIAD, syndrome of inappropriate antidiuretic hormone. Most common, euvolemic, no edema, urine sodium usually greater than 40 milliequivalent/L, volume depletion, hypovolemic, GI losses, diuretics, adrenal insufficiency, signs of low ECF volume, urine sodium often less than 20, and less renal losses, heart failure/cirrhosis, hypervolemic, edema, ascites, jugular venous distension, urine sodium often low, less than 20, due to effective arterial blood volume reduction. Endocrine, hypothyroidism, adrenal insufficiency, both can cause ADH elevation. Drugs, SSRIs, carbamazepine, NSAIDs, desmopressin, etc. Nausea, pain, post-operative state. Non-osmotic stimuli for ADH. Step 4. Use urine sodium and clinical volume status to narrow. Urine sodium equals 45 milliequivalent/L. This is not very low. It suggests that sodium avidity, renal retention, is not extreme, which points toward euvolemia rather than severe hypovolemia or hypervolemia with low effective circulating volume, both of which typically give urine sodium 20 to 30 milliequivalent/L, except in renal causes of volume loss like diuretics or mineralocorticoid deficiency. Clinical volume assessment. The patient is elderly, no edema, no orthostatic hypotension, normal skin turgor, and no signs of heart failure, no RALs, no JVD. So she appears euvolemic. Euvolemic hyponatremia plus inappropriately concentrated urine plus urine sodium greater than 40 milliequivalent/L, most consistent with SIADH. Step 5. Rule out other causes of euvolemic hyponatremia. Hypothyroidism. Check TSH, free T4. Adrenal insufficiency. Check morning cortisol plus or minus ACTH stimulation test. Drug history. She reports no new medications, but confirm, e.g., an SSRI started recently, desmopressin, carbamazepine. Primary polydipsia would have very dilute urine, urine osmolality less than 100, so not this case. Reset osmostat, rare. Urine osmolality is usually not as high as 450 in the face of plasma osmolality 260. More typical would be a lower urine osmolality that is still inappropriate for the degree of hyponatremia, but not fixed high. Can be considered if other causes excluded. Step 6. Additional tests to confirm SIAD. Serum uric acid, low in SiADH, usually less than 4 milligrams per deciliter. BUN, often low due to dilution. Fractional excretion of sodium, FeNO, typically greater than 1% in SiAD if sodium intake is normal, but not always needed. Chest imaging, to rule out lung pathology, small cell lung cancer, pneumonia, etc. Brain imaging if neurologic symptoms or suspicion of CNS lesion. Step 7. Interpret the urine osmolality in context of treatment decisions. A urine osmolality of 450 mosm/kg is moderately high. This tells us that the patient is unable to excrete free water efficiently. If we give her a fluid bolus of normal saline, the sodium will be excreted along with the water because the urine is still concentrated, and her sodium may not rise or could even fall. The correct initial treatment for chronic SIAD with moderate symptoms is fluid restriction, e.g., less than or equal to 1 L/day, not for saline. If the urine osmolality had been 500, 600 mosm/kg, fluid restriction alone is often ineffective, and we might need to consider oral urea or tolvaptan, vasopressin 2 receptor antagonist, for resistant cases. If the urine osmolality had been less than 300 mosm/kg with plasma osmolality less than 270, that might suggest partial ADH suppression or primary polydipsia. Summary of interpretation. Finding. Implication. Plasma osmolality 260 mosm/kg. Hypotonic hyponatremia, true water excess. Urine osmolality 450 mosm/kg. Inappropriately concentrated, ADH is active. Urine sodium 45 milliequivalent/L. Euvolemic profile, not low enough for hypovolemia/hypervolemia. Clinical euvolemia, no edema, no dehydration signs. Diagnosis, SIAD most likely. Next steps. Check TSH, cortisol, CXR, basic metabolic panel, uric acid. Start fluid restriction, 800 to 1000 ml/day. Monitor sodium daily. If sodium falls below 120 or symptoms worsen, consider hypertonic saline cautiously, risk of osmotic demyelination with overcorrection. Identify and treat underlying cause, e.g., discontinue culprit drug, treat lung lesion, etc. Patient 2. A 65-year-old woman presents with gradual onset of fatigue, mild headache, and nausea. She has no significant past medical history and takes no regular medications. Labs. Serum sodium equals 122 milliequivalent/L, low. Plasma osmolality equals 260 mosm/kg, low. Urine osmolality equals 800 mosm/kg. Urine sodium equals 45 milliequivalent/L. Urine osmolality 450 mosm/kg, moderately concentrated. The kidney still has some ability to dilute urine, though not maximally. Urine osmolality 800 mosm/kg, severely concentrated. ADH activity is very high, and the kidney is producing almost maximally concentrated urine. This means free water excretion is severely impaired. In SIADH, urine osmolality often correlates with the degree of ADH excess or the sensitivity of the kidney to ADH. A value of 800 suggests either very high ADH levels, an ectopic source, e.g., small cell lung cancer, or concomitant volume contraction, which can further stimulate ADH. Why management changes with urine osmolality 800? The primary treatment for chronic, asymptomatic, or mildly symptomatic SIAD is fluid restriction. However, the effectiveness of fluid restriction depends on the urine osmolality relative to plasma osmolality. The concept of free water clearance. Free water clearance, CH2O, is the volume of solute free water excreted per day. It can be estimated. CH2O equals urine volume times 1 USM/POSM. When USM/POSM, free water clearance, is negative, you are actually retaining water, not excreting it. The higher the USM/POSM ratio, the less free water you can excrete even if you restrict fluid intake. Usum 450/POSM 260 about 1.73. With fluid restriction to 1 L/day, the patient may still have negative free water clearance, but might slowly improve. Usum 800/POSM 260 about 3.08. This means that for every liter of urine output, the kidney is conserving a large amount of water. Even with strict FR, e.g., 800 milliliters per day, the patient may not achieve a negative water balance because the urine is so concentrated. Clinical bottom line: when Usum 500 to 600 mosm/kg, fluid restriction alone is often ineffective or too slow, and additional measures are needed. Adjusted management for Usum 800 mosm/kg. Intervention: roll in Usum 450. Roll in Usum 800. Fluid restriction, less than or equal to 1 L/day. First line, often effective. Usually insufficient as monotherapy. Still try, but prepare for failure. Loop diuretics, e.g., furosemide. Not typically used. May be added to promote water diuresis by interfering with countercurrent concentration. Must replace sodium and potassium losses. Oral sodium chloride plus loop diuretic. Not standard. Combined therapy, e.g., 1 to 2 g-NaCl plus furosemide, can increase solute load and water excretion. Oral urea, 15 to 30 g/day. Second line for resistant cases. Highly effective, increases solute excretion, forces water diuresis, well tolerated, but taste is unpleasant. Vasopressin 2 receptor antagonists, tolvaptan, conivaptan. Reserved for severe, refractory hyponatremia. More likely to be needed. Tolvaptan directly blocks ADH action, rapidly raises sodium, risk of overcorrection and high cost. Hypertonic saline, 3% NaCl. For severe symptoms only, seizures, coma. Same indication, but the rise in sodium will be more unpredictable due to very high ADH activity. Close monitoring essential. Step-by-step management for Usum 800. Assess symptoms. If mild, headache, nausea, proceed to outpatient or ward management. If moderate, confusion, vomiting, admit. Start fluid restriction. Limit to 800 to 1000 ml/day. Check daily sodium and urine osmolality after 24 to 48 hours. If sodium does not rise by 2 to 3 milliequivalent/L in 48 hours, common with Usum 800, add loop diuretic, e.g., furosemide 20 to 40 mg/day, plus oral sodium chloride, 2 to 4 g/day in divided doses. This increases solute excretion and promotes water loss. Monitor potassium, magnesium, and volume status. If still no improvement or sodium falls, start oral urea 15 to 30 g/day. Urea is a solute that obligates water excretion. It is very effective even with Usum greater than 800. Side effects: nausea, bitter taste, can mix with juice. Reserve tolvaptan for cases where urea is not available or not tolerated, or for severe, refractory hyponatremia with Usum greater than 800. Start low, 15 milligrams per day, avoid in liver disease, and never use in hypovolemic hyponatremia. Monitor sodium closely to prevent rapid overcorrection, greater than 10 milliequivalent/L in 24 hours. Why the threshold matters. Usum 450 fluid restriction alone works in about 70 to 80% of SIDE patients. Usum 600 to 700 success rate drops to 50%. Many need additional solute. Usum greater than or equal to 800 fluid restriction alone is often futile because the kidney is so efficient at conserving water that even minimal intake leads to positive water balance. You must actively increase solute excretion or block ADH. Comparing management, Usum 450 versus
Usmo 800.
The degree of urine concentration markedly influences the approach to treating hypotonic hyponatremia due to SIADH. When urine osmolality is 450 mosm/kg, fluid restriction alone is likely adequate for most patients. typically raising serum sodium by 4 to 6 milliequivalent/L over 2 to 4 days. The need for second-line agents such as urea or tolvaptan is uncommon. If additional therapy is required, oral salt tablets with or without furosemide are preferred. The risk of overcorrection with hypertonic saline is moderate, as the kidneys retain some diluting capacity. In contrast, when urine osmolality reaches 800 mosm/kg, fluid restriction alone is inadequate. Sodium may not rise or may even fall. Second-line therapy is commonly needed, with urea preferred over tolvaptan. The risk of overcorrection with hypertonic saline is high because any sodium administered is poorly excreted and water retention dilutes sodium unpredictably. Thus, a more aggressive solute-based strategy is required from the outset. Formula for free water clearance. CH2O equals V multiply 1 usum over posum, where V equals urine volume per day, L. Usum equals urine osmolality, mosm/kg. Posum equals plasma osmolality, mosm/kg. CH2O equals volume of solute-free water excreted per day. Positive equals net water loss. Negative equals net water retention. A negative CH2O means the kidneys are conserving water, making urine hypertonic relative to plasma. The more negative, the less effective water excretion. The CH2O calculation. Posum equals 260 mosm/kg. Patient is hypotonic hyponatremic. Urine volume, V, equals 1.5 L/day. Typical for a patient on mild fluid restriction or spontaneous intake. CH2O for usum equals 450 and usum equals 800 will be computed. CH2O calculation case 1. Usum equals 450 mosm/kg. CH2O equals 1.5. Open parenthesis 450 divided by 260 close parenthesis times 1.5 is equal to 1.5. 1.7308 times 1.5 is equal to 1.5. 2.596 is equal to minus 1.096 L/day. Interpretation. The patient has a negative free water clearance of about 1.1 L/day. This means that even if she drinks nothing, her kidneys are retaining 1.1 liters of water per day because the urine is more concentrated than plasma. She would need to restrict fluid intake to less than 1.1 L/day just to maintain sodium balance, and even less to slowly correct hyponatremia. CH2O calculation. Case 2. Usum equals 800 mosm/kg. CH2O equals 1.5. Open parenthesis 800 divided by 260 close parenthesis times 1.5 is equal to 1.5. 3.0769 times 1.5 is equal to 1.5. 4.615 is equal to minus 3.115 L/day. Interpretation. The patient has a markedly negative free water clearance of about 3.1 L/day. Her kidneys are retaining over 3 liters of water per day. A negative free water clearance of minus 3.1 L/day does not mean the patient gains 3.1 L of water with zero intake. Rather, it indicates that compared to excreting isotonic urine, the kidneys are reabsorbing an extra 3.1 L of water each day. In steady state, this reabsorbed water matches the patient's intake. Because the urine is so concentrated, even modest fluid intake leads to positive water balance and worsening or persistent hyponatremia. Therefore, fluid restriction alone is insufficient. You must increase solute excretion, urea or loop diuretic plus NaCl, to lower the usum/posum ratio and allow free water excretion.